شهرزاد طب الأطفال الدكتورة سناء يوسف، وشهريار طب الأطفال طبعا الدكتور إيهاب خيري، بنشكره جدا. والجميلات بقى اللي أنا هقولهم لازم نشكرهم، الدكتورة ياسمين جمال والدكتورة مي نصار والدكتورة مروة الديب، والعسلات الصغيرين بقى الدكتورة مروة حسني وهبة عصام وبسمة عبد الناصر وهايا عصام وعبير محمود ومريم ناجي، كل دول بنشكرهم. الحقيقة لو احنا قررنا ان احنا نعمل زي ما كل حاجة في الاطفال عندنا بنعمل لها جايد لاينز، يعني لازما الخطوات الاسترشادية دي بنمشي عليها. فلو قلنا هنعمل جايد لاينز للايديال سبيكر اللي ممكن يكون موجود بيننا، من حيث طبعا الحضور، من حيث التألق، من حيث العلم، من حيث اللغة، من حيث الرشاقة، كل دول هيجتمعوا في الدكتورة رشا طريف اللي هنستمتع بيها دلوقتي.
مساء الخير على حضراتكم. طبعا انا مش لاقيه كلام ارد بيه على الدكتور محمد زنوب، مفيش كلام يتقال. ربنا يخليك يا دكتور محمد، يعني بشكرك على التقديم الرائع ده، مفيش احلى من كده، ربنا يخليك. وبشكر التشير بيرسونز، وطبعا بشكر استاذتي العزيزه الغاليه الاستاذه الدكتوره سناء يوسف على دعوتي، دكتور ايهاب خيري صديقي العزيز واخي العزيز، دكتوره ياسمين جمال، دكتوره مي نصار، الحقيقه يعني كلهم حبايبي وبموت فيهم، وببقى مبسوطه جدا وانا participating في ميتنج esteemed زي كده. هتكلم عن الشورت تشايلد، وبرضو احنا الجروث والنيوتريشن بيكملوا بعض، ففي بينا شويه اوفرلاب، بس انا هاخدها اكتر من الاندوكراينال بوينت اوف فيو. هتكلم عن the short child to treat or not to treat with growth hormone، خصوصا ان احنا كتير بيجي لنا اطفال قصيرين وما بنبقاش عارفين طب ده نديله جروث هرمون ولا ما نديلوش، مين اللي هيستجيب، مين اللي هيستفيد اكتر. And let me open the scene by this interesting cartoon. A question that we as pediatricians and pediatric endocrinologists are asked by parents and sometimes by the patient. Am I short or not? And as you see, most of the children lie at the middle of the bell chart, with some of them being extremely tall and others being extremely short. And from here came the definitions of short stature, which is a height below -2 standard deviation or third percentile for age and sex, height more than 2 standard deviation below mid-parental height, growth velocity below -2 standard deviation or 25th percentile, and finally height deceleration crossing 2 major percentile lines. And the question here is how to think right when facing a child with short stature, because it's not really as simple as we might think. And what if we are stuck in the heavy traffic of this question? Why is the child short? Simply, when evaluating a child with short stature, it's either with dysmorphic feature, and this is the syndromic type of short stature, or the category of disproportionate short stature. If not this or that, we are facing proportionate non-dysmorphic child. And here we have to exclude normal variance, undernutrition, which is a very common cause of short stature, chronic illness, SGA, and lastly, endocrinal disease, which is not the most common cause of short stature. And finally, if we cannot face any of these, no causes there, then it's idiopathic short stature. And this is the simple algorithm proposed by European Society for Pediatric Endocrinology on the approach of a child with short stature, starting by history, physical examination and anthropometric assessment, general baseline investigations, followed by endocrine assessment in the form of thyroid function, growth hormone stimulation test, IGF-1, and finally genetic testing, which is not the case in every child, of course. What about this important discriminating factor? Is the stunting due to nutritional or endocrinal disease? Because this is what faces us as pediatricians at the beginning when the child comes to our clinic, to know whether we're going to refer the child to a nutritionist or to a pediatric endocrinologist. If the child is due to nutritional cause, you're going to have below -2 standard deviation BMI, and the height will be affected as well. The bone age is not delayed except in severe cases, and you're going to find other features of nutritional deficiency. On the other hand, in children with endocrinal disease, the weight is either normal or above normal, and the child is short. So when you face obese, short child, we have to exclude endocrinal disease in addition to delayed bone age, which is a very important feature. So don't forget to exclude nutritional cause before jumping to endocrine disease. Again, nutrition is much more common than endocrinal causes. And this is what I call the short child panorama. A lot of children presenting with short stature. And the question is prescribing growth hormone. It's really easy to prescribe growth hormone. But the question here is it just giving growth hormone to any child with short stature? Is it the magical solution for every child with short stature? Of course, the answer is no, because the question here is who will benefit from growth hormone therapy? So it's not the ideal for every child with short stature. And here we should ask ourselves, which way shall we go? To give or not to give growth hormone? And again, the important question is how to grow right. When giving growth hormone, we need a good response because it's a really expensive therapy. So we need to prescribe it correctly and for the proper patient, because growing right is our target, not just giving growth hormone. And looking at the history of growth hormone, it was first isolated from the human pituitary in 1956. In 1958, it was obtained from cadaveric pituitaries. In 1960, it was clear that growth hormone deficient children could benefit from growth hormone. In 1985, FDA received reports on serious neurological illness associated with growth hormone, and this is the Crutchfield-Jakob disease. And this was the year that witnessed a switch from the cadaveric growth hormone to recombinant growth hormone by DNA technique that we are using right now. So this is what happened in the past. What about the current and the future? You can see here two boxes on FDA and EMA approved indications for growth hormone therapy, and both of them are copy-paste with only one exception. Idiopathic short stature is approved by FDA but not yet in Europe. Now let me take you to the story of this 7-year-old girl who came with proportionate short stature. She's very short, -4.5. Growth velocity is very low. She has doll-like face, excess abdominal fat. And look at the chart. She was okay, and then she plateaued at the age of 3. Celiac screening, thyroid, cortisol, ACTH, everything is normal. And the growth hormone stimulation test by 2 tests is very low, IGF-1 very low, and the bone age is delayed. So this is the typical diagnosis of isolated growth hormone deficiency. And MRI Celatosica revealed anterior pituitary hypoplasia. And here you can see the guidelines, consensus guidelines proposed by Growth Hormone Research Society for diagnosing growth hormone deficiency, and most of references agreed on a cutoff of less than 7 nanograms per ml to diagnose growth hormone deficiency. Now, let me ask you, would you like to give growth hormone for this little girl? To give or not to give? Who says yes? Thank you very much. Of course, this is the first approved indication for growth hormone therapy, and the girl did very well and beautifully catched up her height. And be aware that the growth hormone dose differs in different periods of life, from child, transition period, and adult. Also, replacement of other pituitary hormones is very important to optimize the final height. And the correct sequence is the adrenal, thyroid, and finally the growth hormone. What about the SGA? SGA babies, we all see them, especially those practicing neonatology. And SGA is defined as a birth weight or length less than 2 standard deviation for age and sex. And about 5% are born SGA, with 3 subclasses, either SGA for length or weight or both. Now, let me take you to the story of this full-term neonate who was born SGA and the height minus 2.8. The mother came to me at the age of 1 year requesting growth hormone. What do you think? Who would like to start growth hormone for this child with SGA? Can you raise your hand? Who says yes? Okay, thank you very much. The correct decision is no. We do not start early. We wait, because 80 to 90% catch up the height at the age of 2 to 4 years. So you have to wait until the age of 2 to 4 years to start treatment if the baby does not catch up. Only 10 to 15% will not catch up and require growth hormone therapy. So growth hormone therapy is approved for short SGA children who did not catch up the height. And it is continued until complete epiphyseal closure. You can see FDA approved it from the age of 2 years and EMA approved it from the age of 4 years. So we wait until 2 to 4 years aiming for a catch-up. And here you can see the long-term effect of growth hormone in children born SGA. It optimizes the final height. And discontinuation of growth hormone leads to catch down growth. They decelerate the height if you stop growth hormone before epiphyseal closure. More important is that SGA predisposes to metabolic syndrome. SGA causes defect in the metabolic programming of the fetus, redistribution of the nutrients, placental and fetal hormonal changes, postnatal growth and environment leads to a lot of changes ending by obesity. So SGA babies are more liable to obesity, type 2 diabetes, impaired glucose tolerance, dyslipidemia, hypertension, ending by metabolic syndrome. The nice thing is that growth hormone improves metabolic status of those children. It improves the lipid profile, it lowers the blood pressure, increases the lean fat mass and decreases the fat mass. It even increases the IQ and improves the final height and the bone mineral density. Let's move to this 13-and-a-half-year-old girl who came to me with short stature, delayed puberty. She was born with a low birth weight and length, swelling of the dorsa of the hands and feet, mathematical problems at school, and recurrent otitis media. The baby was short at birth, and then she continued to be short in childhood and adolescence until the time I saw her. The thyroid, the growth hormone, the celiac were all normal, and the bone age was delayed, as you see, and the GnRH test showed high FSH, high LH, low estradiol. So this is a hypergonadotropic hypogonadism, meaning that the problem is in the ovaries, the gonads. And the girl was found to have a horseshoe kidney, but the echo was normal. What is the missing investigation in this girl? Thank you very much. Of course, karyotype. It should have been done from the beginning. It should be done for any short girl, even if not dysmorphic. And this girl proved to have a 45X Turner syndrome. So karyotype is indicated in any short girl, in any girl with primary amenorrhea or delayed puberty or lymphedema or left-sided heart disease, even in the absence of dysmorphic feature. So let me ask you the same question. To give or not to give? Who would like to give? Thank you, everyone. Of course, Turner is an FDA-approved indication for growth hormone. She did very well. And this is the clinical practice guidelines on girls with Turner syndrome, strongly recommending growth hormone in girls with Turner syndrome using a higher dose than this given to growth hormone deficient children. What about this 8-year-old boy who presented with short stature, SGA, learning problem, undescended testes, ptosis, low set ears, Turner-like features like the shield chest, webbing? He was born with a low birth weight and length. Thyroid, growth hormone, celiac, karyotype, everything is fine. And he has pulmonary stenosis. What's your diagnosis? Thank you. This is the typical Noonan syndrome. And by the way, Noonan syndrome is not uncommon. When you have a child with left-sided heart disease and dysmorphic features, shield chest, Turner-like features exclude Noonan syndrome. So to give or not to give, who would like to give for Noonan syndrome? Thank you. Of course, we have to give for Noonan syndrome, and it is recently approved in 2020. It's a very recent indication being approved. What about this cute little boy, 4-year-old boy, very short, minus 4.3. He was born 850 grams, very low birth length, 42 centimeters, triangular face, frontal busing, leg length discrepancy, café au lait patch. Thyroid, growth hormone, celiac, karyotype, everything is normal, and the bone age is only 2 years delay. What's your diagnosis? Thank you. Silver-Russell syndrome. Again, to give or not to give growth hormone? Thank you. Yes, it's recently approved because Silver-Russell falls under the category of infants born SGA who did not catch up. So you have to give Silver-Russell syndrome. What about this 12-year-old boy who came with short stature, obesity? At first, he was born SGA with difficult feeding, weak suckling. He was a floppy infant, and then he started to develop hyperphagia, weight gain at the age of 3 years. The mother also noted intellectual delay and learning disabilities. He also has small hands and feet with a small scrotum and micropenis. What's the suggested diagnosis? Thank you very much. This is Prader-Willi syndrome. And this is to show you the growth chart. He was born SGA, he was very short and continued to be short, especially at the time of adolescence. What about the weight chart? Remember, he was born SGA and then he started to develop dysphagia at the age of 3 years until he became morbidly obese. And honestly speaking, the parents told me that they have to lock the refrigerator because the boy couldn't stop eating. He really doesn't have any satiety. He could eat anything, no satiety at all. And looking at the Prader-Willi eating phenotype, it passes through different phases. At the newborn period, SGA, and then in phase 2, normalizing food intake, excess caloric intake, gaining strength, motor function, and weight. Phase 3, 2 to 15 years, hyperphagia, temper tantrum, reduced satiety with morbid obesity, and then hyperphagia decreases again in adulthood. Indeed, there is impaired growth hormone IGF axis with more tendency towards growth hormone resistance. And there is a long list of comorbidities encountered in children with Prader-Willi syndrome, namely hypogonadism, central adrenal insufficiency, hypothyroidism, bone mineral density defect, growth hormone deficiency, type 2 diabetes, obesity, and sleep apnea. It's very important to screen for these abnormalities in children with Prader-Willi syndrome. The thyroid function was found to be low, low T4, low TSH. This is central hypothyroidism. Adrenal axis was normal, and the fasting blood sugar was impaired, and the oral glucose tolerance as well. Now, can I ask the same question? Shall we go for growth hormone right now? Who says yes? Thank you. We have to think twice. Yes, growth hormone is approved in Prader-Willi, but we have to correct the comorbidities first. This is very important. It was approved in the year 2000. There's a lot of benefits like the linear growth, the body composition, motor function, psychomotor development, but, and this is a very big but, before starting growth hormone in Prader-Willi, full assessment of polysomnography, ENT, blood glucose profile, thyroid, adrenal function should be done to normalize these parameters before starting growth hormone. What about this 14-year-old girl with chronic kidney disease since 4 years? She's very short and her creat is 4.4 and her bone age is 12 years. She's in Tanner stage breast 3. To give or not to give? Shall we give? Yes, of course, I agree. Chronic kidney disease is one of the FDA-approved indications for growth hormone therapy due to clear impairment of the growth hormone IGF axis in those children, but we have to improve the kidney condition as well. Poor growth in chronic kidney disease is very well known, and our target is to normalize the height, the weight, the muscle mass, and the neurodevelopment, and these targets are clearly achieved by growth hormone therapy, and they need larger doses than those with growth hormone deficiency. Now, the second part of the story, this girl stopped hemodialysis and renal transplantation was done since 3 months. She came back to me requesting growth hormone. She's still short. Her bone age is 12 years and puberty came to be 3. Who would like to give this girl? Who would give growth hormone for this girl now? Yes or no? Thank you very much. We wait. We do not start growth hormone in children after renal transplant. It's not yet FDA approved. Treatment should be considered in patients who do not catch up after 1 year of transplant. So you have to wait first. If the child does not catch up, you can give growth hormone. And if we decide it improves the height, as you see here, and there are some few reports relating growth hormone therapy to rejection of the transplant if growth hormone is started early, before 1 year. So this is a very important point to be considered. My last case is the 6-year-old boy with short stature. His birth weight is normal, family history is normal, he's very short, minus 2.7, MRI, pituitary is normal, all his labs, including growth hormone, is completely normal. I couldn't find anything abnormal. What's your diagnosis? Yes, this is idiopathic short stature. And by the way, they are not uncommon. We have a lot of idiopathic short stature in Egypt. It's defined as a heterogeneous group in which the height is more than 2 standard deviation below age, sex, and population, with no evidence of systemic, endocrine, or nutritional or chromosomal abnormalities. And this is a very difficult question I'm asking now. Would you like to start growth hormone? Who would give growth hormone? Okay, who would not give growth hormone? Okay, let me tell you, both are correct. Because there is no clear consensus. It's an idiopathic. We cannot catch the cause. Some references, including FDA, recommend giving growth hormone to ISS patients. In Europe, it is not yet approved because they feel we didn't catch a cause, so it's not cost effective. And the last thing is that we take it on individual base, case by case. If the predicted height will be very short, we start growth hormone. Again, there is recommendation against routine use of growth hormone in ISS patients. Take it one by one, case by case, on individual basis. And finally, to sum it up, whatever the cause, I think you agree that early diagnosis and proper treatment of short stature improves the final height outcome. And what if the time is critical during puberty? Correct decision counts a lot. And sometimes we need to buy the time, and this is very important. There's a very effective treatment for each and every type of short stature, but we need to start early to avoid this very sad story. An adolescent coming to me telling me, please give me growth hormone. I'm very short. And I look at the bone age with complete epiphyseal closure. Unfortunately, I tell him that I couldn't help him anymore because unfortunately, you cannot go back with the time. So once we diagnose short stature, we have to treat early. I hope I was able to answer this difficult question, to give or not to give growth hormone when facing a child with short stature. I'm a very big fan of growth hormone. I agree, it's a magical stick. It has changed the life of a lot of people. It increases the height and it improves the metabolic status, but it is very important to be used wisely by someone who's an expert in using growth hormone. Again and again, this is the list of FDA-approved indications for growth hormone therapy. And here you can see on the right side a very long list of off-label indications for growth hormone therapy. We have to think twice before prescribing growth hormone in off-label indications of growth hormone therapy because there is more to come and the list continues to grow, more and more indications. And we have to balance the decision on individual base. It's a really expensive therapy that we need to think it should be cost-effective when prescribing growth hormone. And please avoid growth hormone abuse because some people take it in the gymnastic halls in order to build muscles. It's a very big market for growth hormone. And some ladies take growth hormone as an anti-aging. Yes, it's very effective, but we need to think twice. Others take growth hormone to decrease the abdominal fat and belly. These are off-label indications of growth hormone. And celebrities, most of them take growth hormone to stay forever young. And above all, Yusra al-Amardi, above 70 years, and she looks very young because she's on growth hormone وطبعا حاجات تانية كتيرة غير الgrowth hormone. I will end by this quote that I believe in. Sometimes you make the right decision, but sometimes you make the decision right. I think we as pediatricians need to make the decision right by pushing the patients toward the right side, using growth hormone properly, referring cases with short stature to be diagnosed and treated early to get the best for those lovely children. And finally, remember, always make the right decision at the proper time to hit the target. Thank you very much for your attention.
هسألكم انتوا بقى كان عندي حق ولا ما كانش عندي حق؟
ربنا يكرمك.
ايديال اور نوت ايديال؟
ده من ذوقك يا دكتور محمد، ربنا يكرمك.
يعني بنشكر الدكتورة رشا على المحاضرة الأكثر من رائعة. فعلا مع الدكتورة رشا متعة العلم.
ربنا يخليك يا دكتور محمد. ميرسي.
شكرا جزيلا لحضرتك رشا هانم، وبنشكر يعني الدكتورة سناء هانم على المؤتمر الأكثر من رائع.